My name is Bernd Kasper. I'm medical oncologist based in Mannheim, University of Heidelberg, Germany. And thank you very much for the kind invitation to speak here at this DTRF meeting. I think it's actually the first time in the last 10 years I cannot join you in person, and I'm really afraid of that for personal reasons. But thanks for the kind invitation, and I will be with you today virtually for two presentations at the end. And I will start with my first one now. And this is the latest edition of the Global Management Consensus from our Desmoid Tumor Working Group. I just want to highlight from the very beginning that this is a joint initiative between us as doctors, medical experts, and patient advocates, namely Sarcoma Patient Advocacy Global Network, the DTRF, the Desmoid Tumor Research Foundation, and a couple of other national Desmoid tumor patient organizations. And I would like to give this presentation on behalf of the Desmoid Tumor Working Group. So Candice already gave a perfect introduction into the topic. When talking about desmoid tumors, we are talking about a rare disease. It's a monoclonal fibroblastic proliferation, and they are characterized by a variable presentation and an often unpredictable clinical course. And this makes it so difficult to treat these tumors. When we started this initiative, and this is now more than 10 years ago, we had no level 1 or 2 evidence for this disease. That means there was no phase 3 study. There were only very few prospectively conducted studies and meta-analysis. So we had a first meeting in May 2014 in Frankfurt, Germany, which brought together medical experts from the ERTC soft tissue and bone sarcoma group together with patients and patient advocates from SPAN. And in this very first initiative, this started all in Europe. And the idea at the very beginning was to harmonize the management strategies for this disease. And we came up with the first position paper on the management of sporadic desmoid type fibromatosis, which we published in early 2015. In 2018, we pushed the whole initiative forward into two aspects. First of all, we did a systematic literature search, which was done by an external institute, which was based in Germany. And secondly, and maybe this is even more important, the Desmoid Tumor Working Group went global. So we invited our colleagues from North America, USA, Canada, from Asia, globally, and had this first global consensus meeting. And we published out of that the first global evidence-based desmoid consensus guideline, and that was in early 2020, again in the European Journal of Cancer. So the latest edition now dates back to 2023, and this is, this shows the workflow and the methodology we followed for this consensus meeting. We started with a kickoff already in November 2022. We then did a literature search at the beginning of 2023. We divided the work into different, let's say, writing committees or writing groups, and drafted a paper, which was actually the basis for the discussion at our in-person meeting in Milan in June 2023. And after that, we worked on the publications. An external literature search and evidence evaluation was done in this paper as well, but not in that extensity, I would say, as we did that for the first paper. We focused here on the randomized trials for systemic therapies, and this was actually supported by a grant from the DTRF. As you cannot cover everything in such a one-day consensus meeting, we thought it might be reasonable to cover what we called the hot topics. And these are the hot topics: the positioning of local therapy versus systemic or medical therapies. When we go for systemic therapies, is there a first line? What are the remaining indications for surgery and radiotherapy? We dedicated much more time and space in the paper at the end to two specific patient populations, the pediatric patients and the FAP patients. We looked at quality of life and benefit, and we updated the overall treatment recommendations. And what I would like to do now is share with you the most important consensus statements of these hot topics. And I will focus a bit on medical therapy. But let's get started with the positioning of local therapies. Cryoablation, you already heard that today, and there will be a specific talk dealing with cryoablation during that day, is maybe the most promising one of the local treatment options for desmoid tumors. There is one prospective study, which is called the CryoDesmo-1 trial, which was performed in France. And according to this trial, the current indication for cryoablation is a growing desmoid tumor after at least 2 lines of medical therapy or with functional symptoms or pain. A multidisciplinary discussion is, of course, essential. You always have to keep in mind that cryotherapy is not available in every center or in every country and requires a very specific interventional radiological expertise. Conducting clinical trials is, of course, always encouraged. This leads us to the available systemic therapies. Randomized phase 3 data, and this is actually the highest level of evidence we have at the moment, only exist for 2 medical therapies, for sorafenib and nirogacestat. And I will like to dive a bit deeper into the data of these 2 compounds. So let's get started with sorafenib. The sorafenib trial was actually published in 2018 and was the first ever phase 3 study which was performed in desmoid tumors. It was a placebo-controlled trial, and there was a clear benefit in favor of sorafenib. The overall response rate for sorafenib was 33%, and it was only 20% in the placebo arm. But I want to dedicate a bit more time to the new compound now, which is called nirogacestat. Nirogacestat is a gamma secretase inhibitor, and I had the privilege as the principal investigator of the phase 3 trial here, which was done with nirogacestat, to present this trial in the presidential session at ESMO 2022 in Paris. And I would like to show you the results, or the main results of this trial now. The trial was called DeFi, which stands for desmoid fibromatosis, is a phase 3 study comparing nirogacestat versus placebo in adult patients with desmoid tumors. It was a global, randomized, double-blind, placebo-controlled phase 3 comparing efficacy, safety, and tolerability of niro versus placebo. 142 patients were randomized in North America and Europe. The primary endpoint of the trial, which I will show you, was progression-free survival. And we captured a lot of what we call secondary endpoints, objective response rate, a lot of patient-reported outcome measures, such as pain, symptom burden, physical role functioning, and overall quality of life. And here are the results. What we called primary endpoint progression-free survival was clearly met, which you can see here. Nirogacestat significantly reduced the risk of disease progression by 71% compared to placebo. The median progression-free survival in the placebo arm was 15.1 months and was not even reached for nirogacestat due to the low number of events. The overall response rate was 41% for niro and only 8% in the placebo arm. Complete responses were only seen with nirogacestat in 7% of the patients. The time to objective response with niro was 5.6 months and was almost doubled in the placebo arm. As I already mentioned, we captured a lot of patient-reported outcomes, and this is just one example here because this study showed a very consistent benefit in favor of nirogacestat in all different treatment, patient-reported outcomes we measured. This is one on symptom severity, where there is a clear favor or benefit in favor of nirogacestat. This was measured by a score, which is called the Goddess score. It's a score which has been specifically developed for a desmoid tumor patients. What about the side effects and the safety profile? Here are the most common side effects with nirogacestat: diarrhea, nausea, fatigue, hypophosphatemia, and rash. However, 95% of these treatment-emergent adverse events are grade 1 or 2 or were grade 1 or 2. And when they occur, they usually occur very early during the first cycle of treatment. There is one very specific adverse event which we call ovarian toxicity. It is defined as abnormal reproductive hormone levels. They can be accompanied by perimenopausal symptoms. And if you look at the graph, 75% of the females of reproductive potential actually showed symptoms of ovarian toxicity. However, in those patients who stopped the drug for any reason, the resolution rate was 100%. And even in those patients who continued nirogacestat treatment, the ovarian toxicity resolution rate was 64%. So overall, we see a resolution in more than 70% of the patient. So it really seems a reversible effect. So DeFi, this study was scientifically published in the New England Journal of Medicine in 2023. But we also published, and this is even maybe more important for you as patients and patient advocates, we published a plain language version or summary of DeFi in Future Oncology earlier this year in January. A study to learn if nirogacestat works and is safe for adult participants with desmoid tumors, a plain language summary of the DeFi study. What's about the approval status for nirogacestat? Nirogacestat is already approved in the US since November 2023, and finally also in Europe in August 2025. So just 1 month ago, the European Commission also approved nirogacestat, or Ogsiveo, how is it called now, for adult patients with desmoid tumors. So coming back to our consensus statements and to the consensus paper, due to the lack of comparative studies, we of course are not possible to give a definitive sequence of the existing treatment options we have. So when it comes to the selection of therapies, you always have to take into account the toxic effects of the individual agents we can use. And of course, you have to take into account the specific patient situation. The richer the armamentarium is, the better it is for patients and physicians, allowing multiple choices. There is always the question about duration of therapy. The problem is we do not have high quality data here, and I actually cannot really answer this question. But the consensus of the group was that a course of at least 6 to 12 months is required prior to assessing effectiveness. What about the remaining indications for surgery? There has been a paradigm shift over the last 15, 20 years from extensive surgeries in these patients. Meanwhile, surgery doesn't play a major role anymore. Only in sporadic mesenteric desmoid tumors, they are only treated with surgery when there are complications such as bleeding, obstruction, perforation. But the goal of surgery here is not to achieve a complete resection. It is more to treat the complication. And for non-mesenteric desmoid tumors, surgery may be discussed when there is a progression on medical treatment or active surveillance, but you always have to take into account the morbidity. Radiotherapy, even rarer, doesn't play a major role anymore. It may be an option when the desmoid tumor is too large for cryoablation, or when surgery would be associated with unacceptable morbidity. And always please keep in mind that radiation is not indicated as an adjuvant to surgery. As I said, we dedicated much more time to pediatric patients, and the rules or the recommendations here are more or less the same. Initial observation is recommended. Tumor resection should be avoided. A first-line therapy is a bit different here. It's a weekly intravenous methotrexate vinblastine regimen. The use of gamma secretase inhibitors in children should be delayed until we have the results available of the specific trial that has been performed in pediatrics, and the duration of medical therapy is more or less the same answer as for adults, 6 to 12 months. It is important to offer these patients an interdisciplinary supportive care because desmoid tumors can have a major impact on many aspects of patients' lives, their social interaction, their ability to work, their relationship. So a collaborative on personalized management is so important, and it should include, if necessary, pain specialists, social workers, psychologists, physiotherapists, and so on. We also developed what we called treatment algorithms or flowcharts for the different situation and for the different localizations. This is just the one at initial diagnosis, and I just want to highlight here that active surveillance remains the frontline approach for the majority of the patient, and only if the desmoid tumor becomes life-threatening or threatening to function or quality of life, there is an indication for an active treatment. And all this has been published in JAMA Oncology in a review article, Current Management of Desmoid Tumors in 2024. So I would like to thank you for your attention. And I would especially like to thank Alex Cronky, with whom I am pushing forward this initiative now for almost or for more than 10 years. Thank you very much for your attention. And happy to take any questions, of course.
Anybody have any questions? You can just walk up to the mic. I have a question. You said that surgery is not a preferred way, although like I had to have surgery, open biopsy. Is that considered the surgery that you wouldn't recommend? Because I think it was after that that I was determined that it was an aggressive tumor. So I'm just curious to see if you don't do an open biopsy, is there another way that you can, that is preferred to find out if you have a desmoid tumor?
I mean, in general, a biopsy, of course, is always the preferred option at the very beginning, but because we need a secure diagnosis, I would say. But yeah, but what we do not prefer is actually to have the tumor taken out initially, and yeah, that's the main message, I would say.
Dr. Casper, what's the difference between a core needle biopsy and an open biopsy?
I mean, an open biopsy is like a surgery. You really more or less take the tumor out, which you usually don't need for desmoid tumors. So you can just, we just need a probe, a tiny bit of specimen, which can then be analyzed by the pathologist. That's enough.
Quick question on regression. Is there any studies or information being done to figure out if you get off of nirogacestat or sorafenib as to whether or not the likelihood of regression following getting off of the medicine?
You mean when after stopping the drug that there is a further regression, or?
Essentially, like if you are on it for a period of time and you become stable, or
Yeah, okay.
to the point where you'd get off. Is there any thought of nirogacestat or sorafenib, if that essentially could get you into like almost a cure point?
Yeah, I mean, we have, of course, more experience with sorafenib for that. What we usually do is we treat the patient until there is a kind of stabilization, and then there is the time where you can usually stop the drug. And in most of the cases, at least from our experience, there is no regrowth again, or yeah. If this is applicable for the gamma secretase inhibitors and for nirogacestat in the same way is not actually clear at the moment. And we do have long-term data with nirogacestat, which I will present later in that meeting. But it's still, the open question still remains how long actually to treat our patients, which we cannot answer at the moment.
Thank you.
Hi, Dr. Casper. For the Ogsiveo, what's your protocol if there's a lot of side effects?
I mean, what you usually can do, and that's something we also did in the registration trial, you can dose reduce. And one of the most frequent side effects, of course, is diarrhea and skin reactions, I would say. And they usually respond quite well to dose reductions. And even when you dose reduce, you usually have a very good effect of the drug. And so this is certainly a possibility.
What's the dose? What do you reduce to?
I mean, you start with 150 milligram 2 times, and then you can, for example, go to 100 milligram 2 times, and so on.
And depend on tolerate. If you can tolerate 100 BID, you can still do 50 BID. You think?
Yes, you can try it.
You can try it. It is, but the 50 milligram BID, 50 milligram, I think, is available. It's very limited, but that's just depending on the pharmacy, right? Do you know any availability of the 50 milligram?
No, it's
Which
usually
pharmacy?
the 100. Yeah, it's the 100 milligram.
100.
That's right. Yeah.
Okay. All right. Thank you.
Hi, Dr. Casper. It's Yating. I have a two-part question. The first is, now that the consensus paper has been out there for a little while, like, how are the doctors learning about it through the sarcoma network? Like, how do doctors get this information, more doctors? And then the two-parter is, as part of the Desmoid community, how can we help broadcast the news and get it in more hands for more doctors as well?
Yeah, I mean, that's a very good question. And of course, we really, and that is, I would even say, maybe the most important mission of our consensus initiative over the last 10 years. We really try to spread the word because I mean, to be honest, we still see a lot of patients initially operated, and so it is still a lot of work, but I think what you actually can do, you can give this to your treating physician if he's not aware of that. And what we are also actually doing at the moment, Lynn already mentioned it, we are working on a lay version of the consensus paper as well. It will be a much shorter version than the whole publication, which is pretty long. And this is something you can also spread around then, of course.
Hi, doctor. I want to know, I don't have a colon, so, and I'm on Ogsiveo. Do you think that has an effect of absorption of the medication? Is that a factor as well, or no?
So you are obviously an FAP patient, I guess.
Yes.
Yeah, I mean, We do not have as much experience with Ogsiveo in FAP patients as we have for sporadic desmoid tumors, as you can imagine. But a couple of patients were also in the registration trial, and we compared these data from the sporadic and the FAP patients, and the effect was actually the same in both patient groups. So obviously, it also works for the FAP patients. That's
Thank
at least what we can say at the moment.
Thank you so much, Dr. Casper.
Sure. I will see you later again.